Welcome everybody to the Animal Heartbeat Live.
Hi everyone, thank you so much for joining us today. We are the Animal Heartbeat, a podcast dedicated to veterinary cardiology. And today we'll be talking about translational cardiomyopathies and translational HCM, which is a very exciting field because, as you will all know, cardiomyopathies affects dogs, cats, and humans. So by discussing and doing research in cats and dogs, we can help humans and vice versa. Humans can help us then understanding cardiomyopathies in cats and dogs. So we are absolutely delighted to have with us an absolutely fantastic panel, and thank you so much for taking the time to join us today.
We're honored. Thank you.
So if you could please introduce yourselves, it would be fantastic. Maybe we start with Professor Mary Sheppard.
Thank you very much for the invitation. And I must say it's my first podcast, and my first podcast was dealing with animal cardiomyopathies. So I am a professor of cardiovascular pathology, specializing particularly in sudden cardiac death in young people. So a main emphasis is on the channelopathies where the heart is morphologically normal and there's electrical abnormalities, which I'm sure you will talk about, and the cardiomyopathies, particularly hypertrophic, arrhythmogenic and dilated cardiomyopathy. So they're my special areas of interest over the past, I'd say, more years than I will care to admit to.
Fantastic. Thank you very much for inviting me. I'm really excited to be here. My name is Juan Pablo Kaski. I'm a professor of Paediatric inherited cardiovascular medicine, so in humans, not in animals. And I'm a consultant paediatric cardiologist at Great Ormond Street Hospital in London. And my area of clinical and research expertise is in inherited heart diseases in children and adolescents, but particularly the cardiomyopathies, and in particular hypertrophic cardiomyopathy. So I'm really delighted to be here and really looking forward to the conversation.
Thank you.
Lovely. Thank you again for the invite. My name is David Connolly. I'm Professor of Veterinary Cardiology at the Royal Veterinary College. Got a big interest in cardiomyopathies. Divide my time between the clinic, basic research, clinical research, and some admin, and as we all do. And really happy to be here.
Thank you all so much for joining us. It's an absolute honour. We're going to start with a definition, and let's focus on hypertrophic cardiomyopathy. Juan Pablo, would you mind defining HCM for us?
Yeah, absolutely. So hypertrophic cardiomyopathy, actually there are different definitions for hypertrophic cardiomyopathy depending on which part of the Atlantic you're in. But in Europe, at least, hypertrophic cardiomyopathy is defined as a disease of the heart muscle that causes abnormal thickening that can't be explained by other conditions. So, for example, can't be solely explained by hypertension or by congenital heart disease or by valvular heart disease. And it literally is just a description of a thick heart. So there are normal values that we use that are different depending on whether you're an adult or a child. But that's the definition. So it's unexplained left ventricular hypertrophy. In North America, the definition is slightly different. So in North America, they only really consider hypertrophic cardiomyopathy to be left ventricular hypertrophy that's caused by mutations in certain genes, in sarcomeric genes, or at least hypertrophic cardiomyopathy that isn't metabolic or neuromuscular or syndromic in nature.
So it's a genetic diagnosis alongside that morphology.
So it's sort of a genetic. So it doesn't have to be genetic as such, but it has to be non-syndromic. If somebody has, for example, hypertrophic cardiomyopathy caused by a malformation syndrome, say Noonan syndrome, for example, in North America, they would consider that to be a secondary hypertrophic cardiomyopathy, not primary hypertrophic cardiomyopathy. I think our European definition is better because I think it reflects what we see in the clinic. So when a patient comes in, you don't know what's causing it to begin with. What you observe is left ventricular hypertrophy.
So in veterinary cardiology, there's a big debate on how do we define hypertrophy? What is the magic cutoff? And maybe we could start with David explaining us how do we approach, what is a thick left ventricle? Because then we would love to hear from you, Juan Pablo, how do you manage children of different size and teenagers? And then if you could also please let us know, Mary, how then on postmortem do you define hypertrophic cardiomyopathy?
So, I mean, I think even in veterinary medicine, there's shades of grey. And we don't define, I mean, I think first of all, we define it very much like the European way because we have such a poor grasp of genetics. And we either don't recognize or see many of these other syndromes like Noonan syndrome, Sheppard syndrome, those kind of things. So phenotypically, we're looking at thickened ventricular walls. I mean, there's discussion how you measure those in B mode or M mode, and there's certainly differences between that, but we're kind of saying less than 5.5 we'll probably consider normal. 5.5 to 6 millimeters, thickness of the wall, 5.5 to 6 millimeters would be equivocal, which I think is the safest thing to say. Check again, and beyond 6 millimeters, we're starting to feel more confident. But we'll do that in combination with other factors as well, like papillary muscle changes and mitral valve changes. So, we can get certain situations where you haven't got particularly thick walls, but you've got very abnormal-looking papillary muscles, and then there's all sorts of shades of how to interpret some of these things. That's probably not helped you.
I think we were expecting some uncertainty. So we're using an absolute cutoff value to define hypertrophy, but in the context of the rest of the architecture of the ventricle.
I mean, you'd probably go for 6 millimeters or greater, but people would argue potentially with that. But I think that's reasonable.
And how about in people?
Yeah, so in people, it's sort of similar. There is an absolute number. So what I would say, though, is that we're talking here about the definition of left ventricular hypertrophy in the context of hypertrophic cardiomyopathy. But as you've shown, actually, there are lots of pre-phenotypic features that make you suspect that somebody might have hypertrophic cardiomyopathy, even if they don't reach that threshold. But the threshold of definition in adults is 15 millimeters. So if your maximal left ventricular wall thickness is 15 millimeters, then that's diagnostic for left ventricular hypertrophy in the context of hypertrophic cardiomyopathy, as long as there aren't any other things that can explain that degree of hypertrophy. Unless you have a family history. So if you have a family history of the condition, then that threshold goes down. It's 13 millimeters, and that's because your pre-test probability is much lower. Most of these cases, as I'm sure we'll discuss, are autosomal dominant. So you've gone from having a, say, population prevalence of 1 in 500 to having a risk of 1 in 2 of inheriting the condition. So in the context of family history, maximal wall thickness is 13 millimeters. In children, we don't use absolute numbers, but we use Z-score. So we try to normalize for body size because, as you've alluded to, children are growing and changing, and so having an absolute cutoff would be inappropriate. So what might be 6 millimeters, for example, might be a little bit thick for a neonate, but it would be completely within normal limits for an older child or an adolescent. So we use Z-scores based on normative data, and by definition, a Z-score of more than 2 is, in theory, diagnostic for left ventricular.
And Z-score is like a standard deviation.
It's a standard deviation, so it's 2 standard deviations above the population mean. Yeah. It's interesting because there is now a move towards potentially redefining the thresholds for left ventricular hypertrophy in adults, also based on body size, because a 90-kilo male is not the same as a 45-kilo female, for example. And so there are some data emerging now from cardiac MRI, for example, to suggest that different thresholds might be diagnostic at in different sort of body sizes, and also in different bits of the heart. So, for example, at the apex, you expect the wall thickness to be lower than it is at the base, and so the threshold of 15 millimeters might be way too high to diagnose apical left ventricular hypertrophy, for example. But and we're talking here about wall thicknesses largely on echo, but also on cardiac MRI, which is very different to what Mary sees.
Yes. Well, what I see is, because I specialise in sudden death at St. George's Hospital, I'm a national referral centre where I receive hearts from throughout the country. And tragically, we get guess how many hearts I get per week from young people who die suddenly in this country? Could anyone give a guess?
5.
Under the age of 40, we consider young.
Very young.
get 15 to 20 hearts.
Wow.
And so we built up a database to say that of 8,000 cases. And you said a very good point about what's a normal heart and what's an abnormal heart. And it's been a big problem in pathology, the guidelines and criteria for diagnosis. And what we had a big issue in pathology, A, with what is a normal heart rate, and B, what is hypertrophic cardiomyopathy. So we actually measured 1,000 hearts of normal people, and our threshold, when we do, is heart weight itself. We just don't do thickness, we do the weight of the heart. So the weight of a heart above 500 grams in a male, 400 grams in a female. And as you said, Juan, there's a dramatic difference between male and female hearts. So that's very important. Also, the amount of fat around the heart for arrhythmogenic cardiomyopathy is females get a lot more fat around their hearts compared to males. We don't know why in the normal heart. So the weight of the heart is very important for anything above 500 in a male. I now refer to male, preferably above 550. We consider to be a hypertrophied heart. And like you, we measured the thickness, and again, above 15 millimeters, but we think in females it should be less, it should be 13. In addition, we look at a fixed heart, and there's a big problem also in interpretation by pathologists, because some people die where their heart hypercontracts, but the heart rate is normal. There's an increased thickness, but the heart rate is normal. It just simply is, you should say, arrested in systole. But pathologists overinterpret that as hypertrophic.
I think we have the same issues in veterinary pathology.
Have you?
We often think the heart dies in systole is what we talk about. So measuring wall thickness post-mortem is highly unreliable, but I think heart weight to body weight ratio is what we would use. And I know there are veterinary pathologists in the audience who may correct me on that, but that's my understanding. And that's what we do in puppies at the moment. We're quite interested in congenital heart disease in puppies, and we're looking at heart weight to body weight ratio.
And histologically, Mary, then okay, you have weight in the heart, maybe the heart is higher than 500 grams. Then histologically, how would you define, what are the hallmarks of hypertrophic cardiomyopathy and histopathology?
As the history is very important to make sure there's no history. Well, there can be. Hypertension brings out the phenotype. If you've got hypertrophic cardiomyopathy, and getting hypertension as you get older will manifest earlier in life if you've got hypertension. We get a history, have they hypertension? We eliminate valve disease, we eliminate particularly aortic stenosis, be it congenital bicuspid valve or be it calcification later in life, which can lead to massive hypertrophy. We also eliminate metabolic disease. Now, histology is the absolute core to my diagnosis of hypertrophic cardiomyopathy. The important thing we do is sampling the heart. If it's hypertrophied, we will sample from the hypertrophied area and the non-hypertrophied area as well. Now, the major areas where the hypertrophy occurs is the septum between right and left ventricle and the anterior wall of the left ventricle. But it can be apical, it can be basal, it can be anywhere right ventricular hypertrophy can occur. And we then sample at least 7 to 10 blocks. I never tell, if a pathologist takes only one block, I say you are being negligent, because your interpretation of one block can be very limiting. Because a big challenge for pathologists is that one area of the heart may show disarray, but another area normal. Now, why would a mutation affecting every myocyte, disarray doesn't manifest itself histologically, is simply one of the mysteries of pathology. So the more you sample, the more confident you become of the diagnosis.
And how much disarray do you need to say
which I published on, is at least 2 blocks in which 50% of the block has myocyte disarray, not just one little tiny focus. I also tell pathologists, be careful where you sample. Where the septum meets the anterior or posterior wall of the left ventricle, you get disarray because two chambers are meeting, septum to anterior wall, so the myocytes will crash up against each other and give an impression of disarray. So you avoid sampling those. You take from the free lateral wall and from the middle of the septum. I'm very careful about that sampling. We also don't rely on the right ventricle for histology because that normally is disarray because of the prominent trabeculation of the right ventricle. Normally I sample at mid-ventricular level and I'll take the hypertrophied and the normal looking area. But even in hypertrophied areas you may have no disarray, whereas in the normal areas you may get disarray. But I have to see disarray in at least 2 blocks, 50% in the left ventricle. And away also from areas of fibrosis and scarring, because you'll get myocytes disorganized around areas of scarring as well. And even in the teenagers and the young people who die suddenly, they have extensive scarring. So we've got, I often tell my trainees, if you're unsure, go back and resample. And the big issue is the cost of doing the histology. I'm glad to say that most coroners do not mind you taking 7 to 10 blocks. I tell coroners now, the pathology should at least diagnose on 7 to 10 blocks from the left ventricle to be absolutely confident, because you're giving a very serious diagnosis to that family. What I always think, like the diagnosis of cancer, 2 opinions. If I'm going to diagnose hypertrophic cardiomyopathy or be given a diagnosis, I would like 2 pathologists to have seen the myocyte disarray, because there can be over-interpretation of disarray or under-interpretation of it. It's a big issue in pathology.
And it's a big deal, isn't it, that diagnosis for the family?
Absolutely.
In terms of what next for them. So Juan Pablo, can you expand on that and why that's important in terms of following that diagnosis?
Yeah, it's a crucial point, as you say, Mary, because, so as I mentioned before, generally hypertrophic cardiomyopathy is inherited as an autosomal dominant trait. In humans, it's largely caused by mutations in sarcomere protein genes, so the genes that are important for the contractile apparatus of the heart. And getting the right diagnosis has really big implications for how you screen the rest of the family. Because, so for example, if it is a case of, let's say, uncontrolled hypertension that's misdiagnosed as hypertrophic cardiomyopathy at postmortem, we might end up screening lots and lots of relatives for a condition that isn't there, and exposing them to potentially years worth of having to come to hospital and potential anxiety, etc. But on the other hand, and perhaps more importantly, if the wrong diagnosis is made, then we miss the opportunity to screen at-risk individuals. We know that there are young people with hypertrophic, and also, in fact, all of the different cardiomyopathy subtypes would behave in the same way, that potentially are at risk of sudden cardiac death if they're undiagnosed. But if you screen them, if you're able to diagnose them, then there are lots of things that we can do that perhaps you can talk about later to reduce the risk of sudden cardiac death in these individuals, both in children and in adults. The correct diagnosis also allows the right genetic test to be done as well. So you can, when I mentioned before that what the definition of hypertrophic cardiomyopathy is, actually that is not a diagnosis in its own right. So hypertrophic cardiomyopathy is not really the diagnosis, it's the beginning of the diagnostic process. And actually everything that we then do in clinic is to try to identify the specific cause. So the ultimate diagnosis actually will be hypertrophic cardiomyopathy caused by a mutation in this particular gene. And so if you get the right diagnosis, it allows you to offer the right sort of screening to other people in the family with the aim of identifying disease early, so that you have a much better chance of them preventing disease-related complications like sudden cardiac death, but also heart failure, stroke, atrial fibrillation, etc.
When you mentioned the autosomal dominance and the inheritance pattern, what I always thought fascinating about children is we generally read that sarcomeric mutations have an age-dependent penetrance. The penetrance is low or incomplete, and we are more familiar with hypertrophic cardiomyopathy affecting young athletes or middle-aged adults. So why would a sarcomeric mutation cause the phenotype at such an early age? Are they all homozygous, or is there something else? Why would the phenotype be awakened so early?
So that's a great question, and actually it's sort of something that I've been working on for the last sort of 10 years, because until fairly recently, there was this impression within sort of adult cardiology in particular that somehow sarcomeric hypertrophic cardiomyopathy just didn't happen in children, that it was super rare, that this is a disease of sort of late adolescence, early adulthood. And that's very, very different to our own clinical experience. And in fact, we published this some time ago now, but we sort of showed that even in pre-adolescent children with a family history of hypertrophic cardiomyopathy, so not probands, not individuals presenting with symptoms where perhaps you might expect there to be a slightly higher prevalence of more severe sarcomeric mutations, for example, but purely in the context of family screening, we pick up evidence of disease in at least 10 or 15% of families in pre-adolescence, so below the age of 12. And it's exactly the same sarcomeric mutations that you see in adults. So they're not different mutations, they're heterozygous, they're not compound heterozygous. I mean, there are some compound heterozygotes, but generally it's heterozygous disease, same mutations. And this idea of sort of variable expression and incomplete penetrance is something that we're trying to understand, I think beginning to understand now. And one possible explanation for that is the likelihood that common variants in other genes, which on their own aren't enough to give you any sort of phenotype, and that we all sort of carry, but when you put those together with a pathogenic variant, they result in, you sort of cross that threshold for that mutation to express itself. And because children generally don't have some of the other environmental comorbidities that can influence sarcomere protein expression, so things like hypertension or diabetes or obesity, it's quite likely that some of that variation and some of that early onset in sarcomeric disease in children is probably explained by sort of a higher polygenic risk, so a higher burden of common variation together with the monogenic sarcomeric mutation. It's a super interesting area.
And is it the same disease practically? What I mean is, a child is diagnosed with hypertrophic cardiomyopathy with the same mutation as, I don't know, their father. Can you expect the same natural history course? If their father experiences sudden death in their mid-40s, can you expect the same thing of that child, or is it more aggressive because it's diagnosed earlier?
So that's a great question. So there are certainly some families where the phenotype seems to track within the family. Males are affected and they have ventricular arrhythmias in their 30s, and you see that sort of quite consistently. That's actually the exception. So most of the time in families, there's huge variability. A diagnosis in it depends on why the diagnosis was made. So if the diagnosis is made as a result of family screening, which actually accounts for probably the majority of our cases of hypertrophic cardiomyopathy in childhood now, that doesn't necessarily portend the worst prognosis. We just happen to have caught it earlier, and there are probably lots of individuals who were diagnosed with hypertrophic cardiomyopathy in adolescence or early adulthood who, had they been screened in childhood, would have had signs of the disease. But it's certainly the case that if you're diagnosed in childhood because of symptoms, so if you're symptomatic or if you're found incidentally to have hypertrophic cardiomyopathy because someone hears a murmur, for example, then there's no question that the natural history of that disease is shifted. So it's shifted by about 20 years. So you get the sort of the malignant events, whether that's sudden death or progression to heart failure or stroke or AF, it tends to happen around 20 years earlier than it would in individuals diagnosed during adult life.
Interesting.
David, veterinary perspectives on inheritance for HCM in cats. Is this something that you do practically? Do you think about genetic testing? Do you think about screening affected, like littermates or relatives of affected cats?
I think we have big difficulties because, we have two definite variants of significance, and they're both in the myosin binding protein C3 genes, so the main coon and the ragdoll. And we know, for instance, in the ragdoll, homozygous mutation is fairly pathogenic, and you just might work yourself where it showed early death in these cats and poor survival and thick walls heterozygous and wild type were very similar, and survival times were very similar. Beyond that, we've got a variant in domestic short hair in the mice in heavy chain, which possibly is of significance. You know, none of the follow-up's really been done. We've been doing an awful lot of work, which has made things even more cloudy, I'm afraid. I'm going to be the person here. And so kind of what we're certainly seeing some hits. So looking across a variety of different breeds. So Burman, British Shorthair, Sphinx, so these are all different cat breeds. And looking at genetics, but also at transcriptional changes. And we're seeing hits in various genes and some of the things in actin, actinomycin, and in troponin, and one possibly associated myosin heavy chain. But we're also picking these up in the controls as well. And so we're seeing a lot of intronic and intergenic variants. And these are being picked up both in the affected and in controls, to the extent that there may even be some thoughts that some of these are actually protective.
Right.
And it gets even more complicated. So we think we have a disease in older aged cats of a prevalence of maybe 30%, 35%. I mean, it's a bonkers amount. And I don't know, I mean, I'm just speculating crazily now, but maybe it could even be higher if there weren't these protective elements in the introns, and these could be affecting these non-coding long RNAs or microRNAs, which are all switching on and off genes. So it's getting quite complicated. So going back to your question, because we really only have 2 genes that we can play with, genetic counselling, anything like that is not really done, because we just don't have the knowledge to take that forward.
Can you just step back regarding the histological diagnosis, Mary? Because something I think is fascinating is a condition that you describe of idiopathic left ventricular hypertrophy. So left ventricular hypertrophy without the presence of this array, if I understand it right. That's interesting because when our veterinary pathologists look at heart specimens, rather frequently they do not find this array. So everything seems to suggest hypertrophic cardiomyopathy, the heterogeneous hypertrophy, the heart weight, presence of replacement fibrosis, interstitial fibrosis, small vessel disease. So it seems that all the boxes are ticked, but they do not find this array. And then initially we thought maybe they are not sampling enough. Maybe they don't take enough samples, but there are some pathologists, veterinary pathologists out there now sampling the whole left ventricle, and still sometimes they don't find this array. Could you tell us more about what is that HCM, or is that something else?
Well, I will tell you that 1/4 of all our sudden deaths, half are due to arrhythmias, the channelopathies where the heart is normal in young people. Half. 1/4 are due to cardiomyopathies. And HCM and arrhythmogenic make up about 50% of those. And what you say, but interestingly, idiopathic hypertrophy is now our dominant cardiomyopathy. It exceeds HCM in our series. And it's only with sampling, you're absolutely right, where I said, I don't see disarray. So now pathologists are accepting this as an entity, and we have done family follow-up and screening, and we've done genetic testing, admittedly only a small number, we're continuing. There's no relation to HCM genes. And even in the families, we're not finding other family members affected. So what this is, we don't know. Have they undiagnosed hypertension during life? In other words, hidden hypertension manifesting where the athletes, some of them are athletes. All this is something we're now exploring. In other words, we're seeing exciting new entities. The other entity, which I think you mentioned, is obesity. Obesity can also cause cardiac enlargement. Now with obesity, you get coronary artery disease, you get diabetes, you get hypertension, but we get a group of obese people, particularly over a BMI of 40, where they're not diabetic, they're not hypertensive, and they've enlarged hearts, and they die suddenly. And we're now establishing this entity of obesity cardiomyopathy. Now, for ye cardiologists, that will be a challenge indeed as to, is it pathological? Will it cause sudden death? Is a big issue. So that is definitely an expanding entity. But another point I wish to make is that there's the phenotype, the wide family variation that Juan Pablo talked about. One member of the family, absolutely normal. Females do not get the same hypertrophy as the males in the family. If you have hypertension, you'll manifest itself more. And also, in addition, you must remember, 80% of our HOCMs are diagnosed at autopsy. 80%. In other words, they're not diagnosed by the cardiologist. The family are unaware they have it.
That's a huge number.
That's a huge number. We published it about 2 years ago.
Right.
80% of ours were first diagnosed at autopsy. And most of them did not know they had a family history. So that's why I say to pathologists, if you have a hypertrophied heart at autopsy, particularly in a young person, it is legally binding on you, in my opinion, to take that heart and look at it and sample it very carefully and do the histology and then go back to the family with a diagnosis.
How you diagnose?
Go for it,
please.
yeah.
I was about to ask that.
Yeah.
Yeah, no, go ahead, exactly.
So how do you actually diagnose a HOCM? Is it kissing lesions? Is it abnormal mitral valve? How do you decide it's HOCM?
Macroscopically, you will see the hypertrophy.
Yeah.
And you'll also get the abnormalities in the mitral valve, the thickening of the anterior leaflet, because the septum is thickened, and there's systolic anterior motion of and so it hits against the left side of the septum and gives you a thick lesion, what we call an impact lesion. And that's pretty pathognomonic of HOCM in young people. It may not be in elderly hypertensive. You see it sometimes in hypertensive diabetics. But when we see a thick left ventricle with scarring in the septum anterior wall, thickening of the anterior leaf of the mitral with an impact, but you still have to do histology.
Sure.
I always tell you have to do histology. The other bad news I've got for you, 30% of our HOCMs have a normal heart, macroscopically.
Wow.
The heart weight is normal, the thickness is normal. Yet we see disarray microscopically. So 30% of our normal, you can look normal and histologically it's hypertrophic, even though it's a contradiction in terms. You think of hypertrophic, it should be hypertrophic heart. 30% it's not.
Right.
And particularly with mutations in troponin T, as they say.
Yeah.
So I tell pathologists, even a normal appearing heart cannot rule out hypertrophic cardiomyopathy. The histology is what will rule it in or rule it out.
Right. It's fascinating about the high prevalence of the outflow tract obstruction. It's amazing because I think we, in the veterinary field, think there's a bias towards detecting them clinically because they've got a heart murmur. And someone hears the heart murmur, maybe refers them or whatever, and a diagnosis gets made then. I think we worry more about missing the non-obstructive ones. What's the prevalence like in the clinic for humans?
Yeah, so I think the data that Mary was talking about just now reflects that sort of post-mortem series, isn't it? So I think we do make diagnoses of hypertrophic cardiomyopathy in life, but I think clearly the importance of family screening when an individual has died suddenly is really crucial. So that's to make sure that there aren't any other individuals in the family potentially at risk. But in terms of the prevalence of obstruction, so across the board really, around 25 to 30% of individuals with hypertrophic cardiomyopathy will have obstruction at rest, and probably another 50 to 60% will develop obstruction either on exercise or after a heavy meal. So the sort of provoker, so actually, in fact,
McDonald's test.
Like so in fact, in Italy, it's the pizza test. So yes, you can sort of do an exercise echo, or you can give them a big pizza to eat and then scan them. But yeah, so the prevalence of sort of obstruction, whether at rest or provocable, is fairly high. It's about 60 or 70%. So maybe a little bit lower than that in the pediatric population. But yeah, so obstruction is fairly common.
But regarding provocation, because there's always regarding provocation, we cannot really do Valsalva maneuvers in cats, we cannot put them on a treadmill and echo them at the same
They
time.
have strong opinions
Exactly,
about when we
they
try to
kind of
do that.
don't like that. And I was always interested to know, how do you do provocative maneuvers in children? So if they do not have SAM at rest, how do you look for latent SAM?
Yeah, so cats sound a bit like young children as well, but I think we can't. So it's more tricky in the younger children for sure. Probably also though, most children with hypertrophic cardiomyopathy who haven't got resting obstruction and are very, very young are likely to be asymptomatic. But so we tend to do provocation maneuvers when there are symptoms and there is no LV outflow tract obstruction. Routinely in clinic, we would measure the gradient and look for SAM and mitral regurgitation lying down, but also we get them to sit up. And actually that postural change can sometimes bring about a latent gradient. When they can, we get them to do a Valsalva maneuver, but actually we have to use tools to do that. So it's impossible to ask a young child to do a Valsalva maneuver. But we have sort of tricks that we use. So for example, we get them to try to blow the end of a syringe off, or give them an uninflated balloon and try and blow as hard as they can against the balloon, and that sort of can sometimes help to bring about a gradient. And then in older children who are able to exercise, if they're symptomatic, they haven't got obstruction at rest, then we would do an exercise stress echo. So we'd sort of scan them on the bicycle or on the treadmill.
Wow. David, what's your approach?
We try all sorts of things. I mean, sometimes the mere fact you're echoing the cat is enough to get it excited and upset. I do worry about, since we're giving everything gabapentin now, are we actually going to get no hokum anymore because we chill them all out? But we sometimes try barking at them. I do quite a good bark. And actually,
Can you demonstrate that for us now?
That's a good bark.
That's a good bark. It's a high-pitched kind of Jack Russell bark. And I don't know, the licky licks, it's a kind of a liquid, what do you call it? Cat treat. They go mad for it. You could spay a cat.
It's like liquid crack cocaine. It's salmon flavoured.
Yeah.
They love it. Yeah.
Absolutely. And not only does that make them behave, their heart rate goes through the roof as they try, they virtually eat your hand trying to get the stuff. So various things like that. But I guess being more sensible, I suppose there is no standardised protocol in cats to try and induce hokum, and how that may affect some of the publications, I'm not sure.
And in children, what's the prevalence? Because as you said, in adults, and the outcome prevalence would be 60% if 1/3 is at rest, the other 1/3 as it after provocation. What's the prevalence of outcome in children?
Of obstructive.
Of obstructive,
HCM.
sorry.
Yeah, it's pretty similar. So at rest in our own series, so we have a lead an international consortium of Paediatric hypertrophic cardiomyopathy, which has data from around 65 centres around the world, and actually the prevalence of obstruction at rest in that cohort is pretty similar. It's about 20%. We don't have fantastic data for provocable obstruction in the paediatric population yet, but again, from our own experience, it is around another sort of 30-40% at least who develop obstruction on exercise, if not more. So I think that the prevalence of obstructive disease is pretty similar in children compared to adults. But non-obstructive disease is really important in our population as well. You mentioned worrying about missing non-obstructive disease. Actually, probably the group of patients that I find most difficult to treat in my clinic are not the obstructive patients, but it's patients with severe non-obstructive disease who have a slightly restrictive physiology, who are sort of on the trajectory to developing systolic dysfunction. They're often very symptomatic. They have a lot of microvascular disease, so they have lots of chest pain or sort of anginal type of symptoms. So actually, there's a big focus on obstruction, also because there are treatments for that sort of subgroup of patients. But actually, a subgroup of non-obstructive patients are really important to pick up as well.
You mentioned chest pain. Do we see chest pain in cats?
We think we might do it. That's really interesting what you said, because we've always, where we think we see it is actually in the obstructive cases. But maybe we're just missing and not thinking about non-obstructive cases that might also show chest pain. So we sometimes see cats, and we recognize, I say, in the more severe obstructive cases where they do some kind of exercise, running around, and then they fairly acutely stop, very anxious, may open mouth, breathe, and we get, if we can't tell, but we get the concept that maybe hypoxic and showing signs of pain, angina, and they can respond to atenolol, so beta blocker, to reduce the level of inotropic support, and that does seem to help in many cases. But I'm fascinated with the idea that non-obstructive possible cats we might be missing in.
How do children articulate that?
To be honest, most children are able to tell you if they've got chest pain or if they're unwell. They also feel, they also look different. So the parents often notice they become very pale, they're sweaty, they stop doing what they're doing, they don't exercise as much as their peers. But actually chest pain is probably an easier symptom to pick up in children than sort of breathlessness actually, right. or exercise intolerance. That's a more tricky symptom to quantify in the pediatric population. So we use New York Heart Association functional class as the sort of standard way of assessing how symptomatic someone is, and that's a bit more tricky to do in children. Chest pain's usually, I would say, a fairly easy symptom to elicit.
We'll come back to Occam when we discuss treatment later on. But another fascinating area are HCM mimickers, HCM phenocopies, diseases that mimic hypertrophic cardiomyopathy on echo or post-mortem. Would you ever, we'll talk about how to maybe to diagnose them in imaging, but would you ever do endomyocardial biopsies in cases suspected of an HCM phenocopy, or do you rely more on MRI?
The role of endomyocardial biopsy now in cardiomyopathy is becoming non-existent.
Okay.
Yes, if you're a differential,
where
it's usually used to eliminate things.
Okay.
For instance, phenocopies like Danon disease. There's also, Fabry disease, which is a disease, a metabolic disease in older males, manifests younger, females later in life. Fabry's, you get vacuolation of the myocytes because they're full of sphingolipid. It accumulates within the myocytes. So you don't get vacuolation normally in myocytes. You do with poor ventricular function, but only in the subendocardium. Whereas in Fabry's, you'll get a trout. So biopsy may help you there, but generally, genetics, blood tests and genetic testing will help you with Fabry's. The other condition, mitochondrial cardiomyopathies in children, you're more familiar with. The storage disease is very important. I always tell pathologists, look for vacuolated myocytes in the rare biopsies that are done. But biopsies for diagnosis of HOCM, no. Because the problem with a biopsy is that generally the cardiologist will go into the right side of the heart, right? And will go in and take from parts of the septum and only from the subendocardium. And you will not get disarray there. I've never hardly seen disarray. So using biopsies for disarray is, to me, impossible.
My question was, because my question was, what I was hoping to get to ask you was about myocarditis. Can myocarditis mimic cardiomyopathies? And in those cases, how do you approach those cases?
Yes, because it's swelling of the heart with myocarditis. It's unusual enough, though, because persisting. If you have a real swollen heart, and I'm sure with PET positivity and imaging, all the rest of it. But myocarditis, the diagnosis is both over and under diagnosis, as you know. And you're right, where we use it to eliminate diagnosis, like sarcoid is another inflammatory disease of the heart that can give enlargement of the septum and involve the conduction tissue. So biopsy can be useful for eliminating myocarditis. Not eliminating it because the sampling error can occur, because as you know, inflammation can be quite distributed and focal, so you may miss it.
And
the same with granulomas and sarcoid.
I think for most phenocopies, usually we can make the diagnosis clinically. So with a combination of sort of imaging, the ECG features. There are certain red flags on the ECG that are very typical for certain storage disorders, for example, blood tests of elevated CK levels, for instance, in certain conditions, and other sort of extra cardiac red flags as well. So I think, you know, usually we can suspect a diagnosis of a phenocopy, and then we usually confirm it with genetic testing. So Danon disease, often you don't need genetic testing to make the diagnosis because the features are so typical. The ECG is very typical. The echo looks very typical. They often have pigmentary retinopathy. The pedigree is incredibly important. But pedigree, I mean family history.
Not the certificate from the calendar.
Not the certificate, correct. Because, you know, there's an X-linked inheritance. So all of those things are really helpful, and then you can confirm it with genetic testing. I think I completely agree with Mary. I think the role of endomyocardial biopsy is really very limited now in the diagnosis of cardiomyopathies, other than for, you know, certain things, certain inflammatory heart diseases. And I think it would be unusual for a myocarditis to present like a hypertrophic cardiomyopathy. It can certainly present with left ventricular dilatation, systolic dysfunction, so it can look like a dilated cardiomyopathy, and in fact, in many cases, it progresses to a dilated cardiomyopathy. But you do sometimes see edema, and it looks like LVH on your echo, but it doesn't look like hypertrophic cardiomyopathy, and the clinical presentation usually gives the game away, I think.
David, I'm keen to hear your thoughts from the veterinary perspective on what we've been talking about, myocarditis and phenocopies, other phenocopies in cats.
So, I mean, I guess the big phenocopies we think about are things like hypothyroidism. So older cats can obviously get HCM, but they can also get thyroid disease, and that can present certainly with LVH. It can sometimes present more with a dilated type phenotype, with hypersomatotropism, and of course Kieran did some nice work on that. So we had a series of cats which have pituitary tumours and certainly present with thick LVH type hearts, which on histopath, that's quite interesting as well. I mean, even they appeared to have a bit of myocyte disarray, some fibrosis, which...
Fibrosis was quite a big feature of those cats on histopathology, and Lois Wilkie did the pathology on that, so, you know, reasonably experienced veterinary cardiac pathologist looking at it, and that they weren't the same as hypertrophic cardiomyopathy. They were different.
There were
the fibrosis
on the
was
histopath, and the LVH resolved when the pituitary tumour was snipped off by clever neurosurgeons. I guess, I mean, more of the inflammatory thing, or inflammatory, what, you know, the transient myocardial TMT. So this is a condition which I don't think we fully understand, but we think is probably associated with an acute insult, and there's often a cat that is doing fine, but then something bad happens in its life, like usually it ends up in a vet's having a dental or something like that, or is spayed, and then acutely presents in congestive heart failure with somewhat raised troponin, and we often measure troponin I, with LVH on echo, and, you know, we thought, oh, he's got primary hypertrophic cardiomyopathy, but we found that over time the LVH resolved completely, and the cats, you know, went on and
that's really interesting. Is there a particular
Takotsubo?
Yes, that's exactly like a Takotsubo,
that kind of thing. We're not seeing the kind of dilation.
Is there a particular distribution to the LVH?
Not
though,
really.
or no?
Is there?
Okay.
No, I think
I get the feeling it's more symmetric than the sort of classic asymmetric HCM distribution that we might see.
We just
we
just recently looked into that. So, because as David was saying, these cats present with an HCM phenotype in congestive heart failure, but then over time there is reverse remodeling, then the wall thickness normalizes, and as Juan and Pablo was saying, we believe this is myocardial edema because sometimes the thickening resolves in a couple of days. And so suggests that it must be edema. And then indeed our suspicion is either an acute fulminant myocarditis or a Takotsubo stress cardiomyopathy. We published all together, the RBC group, Kieran, myself, a case series, Virginia, a case series of these cases of transient myocardial thickening, where we compare with a group of HCM cats. And now we have been looking at that because we still cannot predict which case we normalize, which case are transient thickening versus HCM. And we are just submitting some data for our next meeting where we looked at different potential variables to predict TMT. And in fact, we looked at symmetry, wall thickening, concentric hypertrophy versus asymmetric, and was not the predictor. I've just received the data today, so it's a bit premature to say what, but troponin I will be very high on. So troponin I seems to be a predictor of transient myocardial thickening. So cats with transient myocardial thickening have much higher troponin I than cats with hypertrophic cardiomyopathy. Wall thickness seems to be a predictor. So hypertrophic cardiomyopathy cats have thicker walls than transient myocardial thickening. So it's a fascinating disease because, of course, the prognosis is much better. But at the moment, because we cannot do cardiac MRI, it's very challenging to do cardiac MRI in cats.
That's what I was about to say, that's what we're lacking, isn't it?
Exactly, to characterize the tissue. But before I forget, because I would love to ask you, Juan, Pablo, because troponin I is something that we very frequently measure in veterinary cardiology, both dogs and cats, and frequently in cardiomyopathic cats when we suspect myocardial infarct or a scar or myocarditis. When do you measure troponin I in children?
That's a great question. So actually, we now do it routinely. So we measure both troponin I and NT-proBNP, which is another sort of marker of ventricular stress. So we measure those routinely now in our clinic. And it's really interesting because most children with hypertrophic cardiomyopathy have normal troponin levels. But there are some patients who are chronic troponin leakers, and the troponin levels are always high. And actually, it's really interesting. So, for example, in Friedreich's ataxia, which is one of these phenocopies, so it's a sort of it's actually a mitochondrial disease, but it causes neuromuscular manifestations, and almost universally they get hypertrophic cardiomyopathy. Those patients seem to have chronically elevated troponin levels, which is really fascinating. BNP, on the other hand, is a very useful marker of disease severity, and it sort of tracks with symptoms and it tracks with disease progression. So we are now measuring those routinely.
That's fascinating because that's what we do. We don't really know what they mean, but that's what we do. It's really difficult. We could be here talking for the next 5 or 6 hours, so we need to. But can I just ask you a cheeky question? We sometimes see cats with thin myocardial segments. So they are cardiomyopathic cats that some left ventricular segments are thick or have a normal wall thickness, and other left ventricular segments are very thin, hypokinetic. And when we have looked histologically, they have transmural scars. And do you see that in children, adults, just thin myocardial segments when the rest of the left ventricle is either thick or normal?
I mean, clinically, yes. So the most common sort of phenotype of hypertrophy, as you mentioned, is asymmetric septal hypertrophy. Usually, most of the other segments are also affected, but there's what we call it relative sparing. So they're sort of less thick than the septum or wherever the maximal wall thickness is. But there are certainly some cases where you do see wall thinning in individual segments, while still maintaining hypertrophy elsewhere. On MRI, you see scar, so those are areas of scarring. There's a particular phenotype where individuals develop apical aneurysms. So and that's that is preceded by thinning of the apex. Again, extensive scarring at the apex, and they sort of slightly balloon out, and that happens in about 3 to 5% of adults, mainly with hypertrophic cardiomyopathy. And then there's a cohort of patients who progress to what we call end-stage disease or burnt-out disease. It's about 5% of people, mainly in adults, very rarely in children, where they thin, they dilate, and they develop systolic dysfunction. And that happens in a patchy way to begin with. So it's not, it doesn't happen universally. So we might see times when there are thinner areas of the myocardium, active wall thinning rather than just relative sparing. But actually, pathologically, do you see that as well, Mary?
We see end-stage remodeled, which the phenotype of dilated cardiomyopathy, and you see this, but they still have disarray. So I warn but generally they present with cardiac failure. Sudden death would be unusual. They'll have a history of cardiac failure in their 50s, 60s. But if there is, and of course, the big problem then is they won't have an autopsy done if they're given a dilated phenotype. So I suspect that the specific HOCM diagnosis is missed because it looks exactly like a dilated clinically and pathologically, but you will still see myocyte disarray.
We talked, we've touched a little bit on sudden cardiac death in people. What do we know about sudden cardiac death in cardiomyopathy in cats?
Well, I think Virginia did some beautiful work on that with Lois, and so, I mean, it's difficult. What they looked at was cats come into pathology where, with sudden cardiac death, and as we kind of said earlier, that an awful lot of these cats get post-mortem because owners think it was a neighbour what poisoned them and that kind of thing. So there's probably an inherent bias there. But I forget the actual figures, but there was a proportion of these cats which certainly had hypertrophic cardiomyopathy, so with either focal or multifocal or diffuse myocyte disarray, small vessel disease, and various forms of fibrosis. So we certainly see that in cats. But I think there's a thing called the REVEAL study where they looked at over 1,000 cats following these through, and in my head I've got figures for sudden cardiac death due to cardiomyopathy is somewhere between 2% and 7%, depending on different kind of publications. So it's that kind of area.
Right.
But again, there's always bias in veterinary publications, isn't there? But that's kind of the figures.
And how prevalent do we think sudden cardiac death is amongst the population of people with hypertrophic cardiomyopathy?
So actually, we've got quite good data on that now, both in adults and in children. So in adults, so there was a bias like you're describing at the very beginning. So the initial studies, 20, 30 years ago, reported very high rates of sudden cardiac death. But actually, we now know that in adults, the sudden death rates with current management are in the region of 0.5 to 0.8% per year. And in children, they're a little bit higher than that. It's about 1.2 to 1.5% per year. So it's there. It's a problem. It's something that is really important for us to identify. But we're really good now, I think, at identifying those individuals who are at high risk. So we have clinical risk models that we've developed in adults and in children that give us an estimate of what the likelihood of a malignant ventricular arrhythmia is over the next 5 years. And these models use sort of routine clinical data. So how much left ventricular hypertrophy there is, how big the left atrium is, whether they've had a history of syncope or non-sustained VT, family history of sudden death, and things like that. And you sort of put these data into the calculator, and it sort of gives you a number. It sort of says your risk of a malignant ventricular arrhythmia over the next 5 years is 6%, 8%, whatever. And then you can use that to implant defibrillators. So you can implant ICDs that are very good at treating malignant ventricular arrhythmias. So the sudden death is a big, and psychologically it's a major issue. But actually, I think we're pretty good at identifying individuals who are at risk, and we're sort of pretty good at preventing that. The big issue now, the long-term, lifelong morbidity and mortality in hypertrophic cardiomyopathy is about heart failure. So we're okay at preventing these individuals from dying suddenly, but actually the disease then progresses. And
they live long enough to get heart failure now.
And they develop heart failure and stroke and atrial fibrillation. And that's actually, I think, where the next sort of frontier in terms of clinical prediction will be.
So the podcast is on hypertrophic cardiomyopathy, but the second most common phenotype we see in cats is restrictive cardiomyopathy. And there's data in the veterinary literature suggesting that maybe RCM is just a late spectrum of HCM, just a later stage of hypertrophic cardiomyopathy, and with some data suggests that cats may share the same mutations. Can you tell us what is known in humans, in children, about restrictive cardiomyopathy? Is that a different cardiomyopathy, or might that be just a spectrum?
It's the least common from the pathologist's point of view. And we really label it as idiopathic fibrosis. Okay. That is where the heart's not hypertrophied, it's normal weight, normal thickness of wall, but we see scarring. And we've no cause, no coronary artery disease, no hypertension. no diabetes.
And no disarray. And no disarray.
Yeah,
Okay.
correct. Oh, definitely no disarray.
Okay.
Absolutely. If there's disarray significant, that is a hokum to us. So there's no disarray. There is fibrosis, but away from there, the fibrosis, we always sample and the myocytes are aligned normally. But it's the rarest form of cardiomyopathy. 5% of our cases would be what we would call idiopathic fibrosis. And restricted is really a clinical diagnosis.
It is, yeah. So clinically, there is overlap between restrictive cardiomyopathy and hypertrophic cardiomyopathy from a clinical point of view. Again, strictly speaking, the diagnosis of restrictive cardiomyopathy is very well defined. So these are hearts that are not thick, that aren't particularly dilated, where the systolic function is not significantly impaired, but there's a restrictive physiology, and morphologically what you see are huge atria, so very, very big atria. But I think actually there are two conditions here. So I think there's restrictive cardiomyopathy, which is pure restrictive cardiomyopathy, has a very bad prognosis, is super rare. And then there's hypertrophic cardiomyopathy with a restrictive physiology, which can look similar, but actually is part of the spectrum of hypertrophic cardiomyopathy. It has a worse prognosis than, let's say, non-restrictive physiology hypertrophic cardiomyopathy, but it doesn't behave in the same way as a pure restrictive cardiomyopathy. So in children in particular, pure restrictive cardiomyopathies, these children are very symptomatic and their pulmonary pressures rise very, very quickly. They become irreversible very quickly, and if they don't get transplanted, then mortality is extremely high. Whereas with hypertrophic cardiomyopathy with a restrictive physiology, which can look similar, actually, it's a much more indolent course. It's more slowly, still not a great prognosis, but it's a more slowly progressing condition. But I think in clinical practice, often pediatric cardiologists label both of those as restrictive cardiomyopathy, but they're not. One of them is hypertrophic cardiomyopathy, and I suspect they would have, in fact, we know that they would have myocyte disarray histologically, and the genetic mutations that cause them are different. So in HCM with restrictive physiology, you have troponin I variants, you have sarcomere protein gene mutations, whereas in pure restrictive cardiomyopathy, it's something else. It's different.
And this is one of the challenges that we come up against, is we don't have that detail on genetics, do we? To be able to say, oh, well, it looked like this, but actually the genetic landscape is this, and therefore we believe it's most likely this. We can't do that.
No, we don't. I don't know, you probably have a degree of longitudinal following these kids and following them into teenagers and that young adults. Again, a lot of what we see is a cat comes and because the owners have to pay for this stuff. And so we don't get that lovely follow-up. In some cases, but in many cases, we don't get the follow-up. So we see this phenotype and we're kind of thinking, is this restrictive? Which sometimes it is, and they don't have a good prognosis. Other times, if I'd seen this cat 3 years ago, would it have thick walls somewhere? And we just, it makes it a lot more difficult.
So we touched very briefly on ICDs as being part of the treatment for these cases. Tell us a bit about medical treatment for hypertrophic cardiomyopathy in people.
So that's, again, it's a rapidly evolving field. So for decades, the treatment of hypertrophic cardiomyopathy was essentially palliative. So and we still do this. So we treat symptoms. If there are no symptoms there, often we don't treat. But if there are symptoms there, we work out why they're symptomatic. Is it because of obstruction? Is it diastolic dysfunction? Is it microvascular disease? And then we used to treat with beta blockers. If it's obstructive disease, beta blockers plus disopyramide, or maybe calcium channel blockers. If it's non-obstructive, then again, calcium channel blockers, maybe sodium channel blockers like ranolazine, for example, if there's a lot of chest pain. But this is really all very empirical treatment. And then there's the sort of prevention of sudden cardiac death side of it. But actually, over the last 2-3 years, there's been a revolution in the management of hypertrophic cardiomyopathy, particularly obstructive hypertrophic cardiomyopathy, with the development of myosin inhibitors, which I understand have also been trialed in cats as well.
Can you tell us more what are cardiac myosin inhibitors and why are they why are they a new type of drug?
So they're the first class of drug that's been designed really to treat the underlying pathophysiology of hypertrophic cardiomyopathy. And sort of pathophysiologically what happens in hypertrophic cardiomyopathy is that the hearts are hypercontractile. So the sort of actin and myosin is permanently bound. They don't relax. They're just constantly contracting. And myosin inhibitors break that bind. They inhibit myosin they're allosteric inhibitors of actin-myosin binding. And so they allow the heart to relax better, but actually they do a lot more than that. So in the adult, mavacamten is the first of its kind. There's a second class called aficamten, which has also now received approval in the US and is about to receive approval in the UK and in Europe. But in the adult trials, what they showed was that in symptomatic adults with left ventricular outflow tract obstruction, mavacamten reduces the gradient, in fact almost gets rid of the gradient in many cases, improves symptoms considerably, improves objective measures of symptoms like VO2, like BNP levels, troponin levels, but also it has an effect on the underlying myocardium as well. So there's a change in LV mass, there's a suggestion that even some of the scarring might change on cardiac MRI. We're currently running clinical trials in children with these, and actually we're seeing exactly the same in children, but really impressive things like the ECG normalizing. So from being very abnormal, it suddenly becomes normal. So these drugs are having an effect at a much deeper level than just treating the gradient. So they're really revolutionary for lots of reasons. First, because it's the first drug ever to be designed for hypertrophic cardiomyopathy. Secondly, because for the first time ever, really, we've had randomized controlled clinical trials in hypertrophic cardiomyopathy. And we now have clinical trials in pediatric hypertrophic cardiomyopathy, which is really unheard of. So everyone's really excited about these drugs. There was a little bit of a dampening of the enthusiasm because there was the adult trial for non-obstructive disease, Odyssey, for mavacamten was negative. So it didn't meet its sort of endpoints. Aficamten is currently still running its non-obstructive trial, Acacia, which I think we'll report very soon. But I think there are reasons why that trial was negative. It was a very heterogeneous population. There were patients there who had mid-ventricular obstruction, which you'd expect would respond to mavacamten very well, and others who probably didn't even have hypertrophic cardiomyopathy, who had hypertension and obesity, and so they didn't really respond very well. So there are clearly some subgroups, and anecdotally, speaking to colleagues who've treated non-obstructive patients as part of the trial, they say there are patients who respond incredibly well and very, very quickly. So I think there is still hope for non-obstructive disease as well.
So it makes sense, wouldn't it?
Yeah.
Because if it's the hypercontractile interacting the actin-myosin, it's not purely the increased afterload by the obstruction.
Exactly. Yeah.
So that suggests that very soon we'll not be using beta blockers anymore.
So that's a really interesting question, because one of the sub-trials of aficamten was a direct head-to-head comparison between aficamten and metoprolol as a beta blocker. There are some, without going into too much detail, there are some study design issues with that, because people came off their beta blocker to go onto the aficamten arm. So maybe the results aren't quite as impressive as they perhaps have been reported. But essentially what they showed was that aficamten worked very well. It improved symptoms, reduced the gradient, etc., whereas beta blockers potentially made things worse. And we sometimes see that clinically as well. So we see that when patients stop their beta blocker, they feel better. So I think it's quite possible that there will be a paradigm shift in terms of how we manage hypertrophic cardiomyopathy.
I think we're at a similar point with managing HCM in cats, or maybe at a similar point with managing HCM in cats. David, tell us your thoughts.
Well, I mean, with regard to the myosin inhibitors, I mean, price is obviously the issue, but certainly they have been used in a colony of cats with obstructive disease, where the obstruction was initiated by isoprenaline,
Isoprenaline.
Yeah.
So, and then the mavacamten was given and beautifully showed the obstruction decreasing and didn't kill the cat, and the cats were fine. So, we know it can actually be used, but price is always going to be an issue with regard to that. There is an alternative which is being looked at, which is rapamycin. And rapamycin is a repurposed drug that was used in renal transplants. And basically they found in some of these renal patients, and also in mice, that it appeared to reduce wall thickness. And so it acts on this mediator which sits in the middle of cellular pathways called mTOR. And by inhibiting that, it can inhibit various hypertrophic pathways and autophagy and things like that. And so there's been a very early pilot trial looking at what we call stage B, so asymptomatic HCM cats, where it does appear to cause some reduction in the wall thickness compared to placebo. And that
or at least a lack of progression.
A lack of progression. Well, if you look at the graph, there was a drop, but then, we're talking millimeters or fractions of millimeters. And so there's an ongoing multi-center trial with the drug at the moment with respect to whether that's going to prove useful. So, that's potentially out there. They're selling it in Italy. I know that we're not using it ourselves at the moment because we're waiting for the full trial.
It's been conditionally licensed by the FDA in the US, really for the purposes of the trial, but it's being used quite widely in the US because cat owners are reading about it on forums and requesting access, and it's out there, they can purchase it. We have imported some and prescribed it to some cats. Who knows if it's doing any good? The attraction for cat owners is, first of all, it's the first drug that might help.
Give it once a week.
Once a week medication because it's so long acting. So for most owners, tableting 2-3 times a day for a cat is a massive challenge. So once they develop heart failure signs and they're on furosemide, antithrombotic drugs, that's enough to contend with. But this is something that most owners that I've spoken to where they've been interested have said, well, it might not work, but it's only once a week. So it's not a big deal for them. But we're at that point where cat owners are very interested and we're all very much waiting for the results of a trial before we kind of make a leap.
That's really interesting because rapamycin mTOR inhibitors and also MEK inhibitors, which is the other sort of bit of that pathway, there's some data now in patients with Noonan syndrome, with rhizopathy syndromes, to suggest that MEK inhibitors and maybe also rapamycin might actually reduce not just obstruction, but also thin the wall in very sick babies with Noonan syndrome. So that would be super interesting. The downside of mavacamten, of myosin inhibitors, is that they cause systolic dysfunction. So you have to be careful and quite lots of monitoring.
Are there any issues there with chronic use? Or do we know? Have we had them long enough?
Myosin inhibitors? No, so mavacamten was licensed in 2022, 2023, I think. So we don't have long-term data yet.
But I think it's fascinating about the cardiac myosin inhibitors. As you're saying, of course, they are negative inotropes. They're going to decrease contractility. But some of the studies that David was referring in cats, where they did pressure volume loops, and they compare pressure volume loops in HCM cats and normal cats, the pressure volume loop normalized, which is amazing, isn't it? That this drug normalized the sarcomere.
After a single dose.
Yeah, after a single dose. That, as you were saying, there are not so many cross bridges anymore, and the ventricle is not hyperdynamic anymore. And it's so clever that the drug can normalize the active myosin interaction.
It's really fascinating, and the preclinical studies of myosin inhibitors in mice, they showed that the mavacamten prevents the development of the phenotype in gene-carrying mice.
I wanted to ask you that, because you mentioned before pre-phenotypic changes. So do you see that happening in the future? Identifying pre-phenotypic HCM and starting a drug to avoid that the phenotype would develop?
Without question, I think that's where the greatest promise for these drugs lie. And actually, I think that's where we're uniquely placed in the pediatric cardiomyopathy world, because we do have these cohorts of children who are gene carriers but haven't yet developed the full phenotype, have very early phenotypes or are pre-phenotypic. And actually, that's sort of a big part of the research program that we're running is exactly that, is understanding how does phenoconversion occur? So how does somebody go from being a gene carrier to actually developing signs of the condition? And actually, but can we identify who are those children who are going to phenoconvert earlier and more quickly, because those are the ones that you want to target in a clinical trial. And then can we develop therapies to prevent that from happening? And that might be myosin inhibitors, but it might be repurposed drugs. But there's some data on spironolactone, for example, potentially doing that as well. So yeah, super exciting.
So there was one final question that I would love to ask you, Juan, Pablo, and then maybe we could see if the audience has any questions. So there's a huge excitement in the human field and now in the veterinary field about SGLT2 inhibitors, because there's an SGLT2 inhibitor license for veterinary use for diabetic cats. and so that drug is already in the market, and yeah, it's been certainly shown in HFpEF patients and so on. Is there any data in humans of the use of SGLT2 inhibitors in hypertrophic cardiomyopathy?
So not yet. I mean, there are anecdotal data. There are small studies in adults with HCM, but there is a clinical trial currently running, Sonata HCM, on an SGLT2 inhibitor in patients with obstructive and non-obstructive hypertrophic cardiomyopathy. So hopefully we will have some data soon. At the moment, SGLT2 inhibitors have a role for treating heart failure, so end-stage disease in hypertrophic cardiomyopathy, but without a real evidence base. But whether they can do something similar to what we've seen with MICE inhibitors, hopefully the Sonata trial will tell us that. There are some really nice basic science data on engineered heart tissue and things like that from colleagues in Amsterdam, for example, suggesting that there is a molecular effect in HCM mutations. But yeah, we're waiting for the clinical.
It's really exciting, isn't it?
Yeah,
there are drugs
extremely.
out there that can affect the natural history, finally. I said it was the last question. You have a last question. If do you want to ask any final question before I...
No, I think we should give people the option
good. I will just grab the
to ask
microphone.
questions from the audience. Does anybody have a question for the panel? Virginia has a question.
Kieran asked me a question.
It's not so far to run. Hi, Virginia.
Hi there. What a treat to have this panel talking about HCM in cats and people. My question was about people with obstructive HCM. Presumably, if they're severely symptomatic, they'll get treatment for it. But do you see the degree of obstruction decreasing over time in patients who perhaps haven't been treated but are symptomatic?
That's a great question. So yeah, so we tend to treat symptomatic obstruction. What I didn't mention before was that there are surgical options too. So if medication doesn't work, then there are surgical or interventional options too. Actually, the traditional medication that we use, so beta blockers, calcium channel blockers, they don't reduce the gradient. They improve symptoms, but they don't really do anything to the gradient. Mavacamten does. Disopyramide sometimes can, at least for a short period of time. But part of the natural history is that, so those individuals who progress towards end-stage disease, and I guess if we followed enough patients up for long enough, most people would at some point be on that trajectory. But they do lose their gradient. So once they start thinning and the systolic function gets worse, then they essentially lose the capacity to generate that gradient. So losing your gradient isn't necessarily a good sign in hypertrophic cardiomyopathy, because it suggests that actually the disease is progressing towards end-stage disease.
That's very interesting, because I think referring vets sometimes think that there was a murmur, but hey, it's gone away. And that usually correlates with a more end-stage sort of phenotype. So, thank you.
Would anybody else like to take the opportunity to ask a question?
Thank you. It's been really, really interesting evening. I was wondering about the obese idiopathic cardiomyopathy. Like in obese children, would you see this happening as well, or is this an adult histopathological diagnosis?
You mean the idiopathic hypertrophy?
Yes.
We see it both in children and adults as well. And what I want to emphasize with Juan Pablo is that we've done a study of childhood HCM or cardiomyopathies up to, the oldest cardiomyopathy case I saw was 95. A HCM at a 95-year-old, she died at 95. Suddenly, no coronary artery disease and nothing, so she had a very good life. So I said, this is a pretty benign mutation if she got to 95. And she'd marked hypertrophy. But idiopathic hypertrophy, again in childhood. But where there's the vulnerability is at adolescence, puberty. There's a big spike in sudden death with puberty, with the muscle growth, and in males, of course, muscle growth and the heart muscle growth. So at vulnerable times between 15, sort of, you know, the females start at menarche, 11 to 14 for females, sudden death spike. For males, it's later because they grow later. So 15 to 17 for the males who saw a spike in sudden death. So that's a very, I'm sure you find the same, very vulnerable period that we see sudden death with extensive fibrosis, you know, well-established, extensive scarring, you know, even a very young person, a very, what we call a very malignant-looking phenotype to us with extensive scarring. But idiopathic hypertrophy, we're not seeing the same spike compared to as we see it in HOCM. So they're quite different entities to what we can see. Now, maybe multiple entities, we simply don't know. The myocytes have no disarray and just look hypertrophied.
But I guess with a sort of obesity epidemic really sort of affecting younger children, we may start to see some of these things.
You're absolutely right.
As well in the pediatric population. One thing that I think is worth highlighting is that things like hypertension, obesity, diabetes, all those things that we mentioned before that are sort of, you make a diagnosis of hypertrophic cardiomyopathy, if you don't have those things, it doesn't mean that you can't have both things together, right? So you can have hypertrophic cardiomyopathy and have valvular heart disease. You can have hypertrophic cardiomyopathy and have coronary artery disease or hypertension or obesity. What I said at the beginning was that the amount of thickening that you're seeing can't be solely explained by those things, but the two things can coexist. And so actually, you know, as you mentioned, hypertension is one of those environmental factors that probably results in earlier or more severe phenotypic expression in adult populations at least.
Yes.
I'm getting a bit worried with our lack of myocyte disarray and our lack of genetics that maybe we're not seeing HCM at all and it's all idiopathic left ventricular hypertrophy.
Yeah. Now, I wonder, as you were saying, David, and as Juan and Pablo was saying, I think initially in veterinary cardiology, we're looking for a monogenic disease, an autosomal dominant monogenic disease. And it sounds way more that this is, most cases we see are polygenic. And as you were saying, there is a threshold. And when all those genes are combined, then we see the phenotype more than probably a monogenic disease. There's just one question that I really want to ask you. And I'm sorry, we could be here the whole day. It's about exercise. And so there was this idea that people with hypertrophic cardiomyopathy should not exercise, right? Because leading cause of sudden cardiac death in young athletes. Exercise is bad, is nasty. But there's a change, right? Now hypertrophic cardiomyopathy patients can exercise. Can you tell us what do we know in adults and children about exercise and hypertrophic cardiomyopathy?
Yeah, so there's definitely been a change, and I think, Mary, you'll correct me if I'm wrong, but I think certainly our clinical experience is that most individuals with hypertrophic cardiomyopathy who die suddenly actually don't die during exercise. They die doing their normal day-to-day activities. Of course, there are high-profile deaths in athletes, which is what sort of triggered that idea, but there's definitely been a change, and for most individuals with hypertrophic cardiomyopathy, it's probably safe for them to exercise, and in fact, we encourage light to moderate intensity exercise in all patients with hypertrophic cardiomyopathy now. If there are no significant risk factors, so if your sort of estimated sudden death risk isn't particularly high, if you don't have significant obstruction, then actually a lot of those patients can probably also do more than mild to moderate intensity exercise with supervision, with a sort of a good sort of exercise prescription package, and as part of a shared decision-making process. We don't have quite the same data for children and teenagers yet, and there's some suggestion, as Mary says, that actually adolescence might be a slightly higher risk time in terms of exercise and sudden cardiac death in hypertrophic cardiomyopathy, but we don't have sort of lots of data for that. But in our clinic, we tend not to restrict exercise for most of our patients with hypertrophic cardiomyopathy anymore.
Kind of long shot, but do you think exercise could affect the phenotype?
So that's a great question, and actually people have thought about this and looked into it, and the answer is probably not. So there's no evidence that for hypertrophic cardiomyopathy, exercise accelerates the phenotype or makes it worse. In contrast, for example, to ARVC, so PKP2 related ARVC, there are relatively good data to show that high intensity exercise can accelerate the development of the phenotype, but not for hypertrophic cardiomyopathy.
I agree with that. When we get an athlete, it's either a channelopathy or arrhythmogenic cardiomyopathy. It's rarely HOCM. So you're right, the phenotype is made worse, aggravated by exercise. So it's one thing we see a lot more with exercise at AR. We call it arrhythmogenic cardiomyopathy now because it involves both ventricles, right and left, not just the right ventricle alone. I don't know about in animals, is it the same thing? Do you see right and left ventricular involvement?
Yeah, I think we do, and I think traditionally we've called it arrhythmogenic right ventricular cardiomyopathy, haven't we, in cats, in dogs?
Yeah, but I think that we have, but we certainly see it in both. I think we're more happy with that one. I was just thinking about the exercise in cats that do nothing for 18 hours a day. Yeah. I don't think it's an issue.
Let's work out a cardiac exercise physio plan for our cats. That'd be challenging.
Brilliant.
Good. Well, thank you so much to our panel. It's getting late, and although I think we could talk all evening, we should probably take the conversation to a bar somewhere. So would the audience like to thank our panel, please, very much? And also just to acknowledge the generous support of Trivium Vet, who sponsored this evening and helped make everything possible. So thank you most of all to you people for coming. This is going to be recorded, so hopefully other people will listen to, and thank you to them as well.
Very good. Thank you so much again for your time. It was fantastic.
Thank you very much.
Absolutely fantastic. Thank you.